Hello everyone, so we are starting with chapter 21, liver disorders, features of liver disorder in children, prolonged neonatal jaundice, more than 14 days of age of term, more than 3 weeks of preterm, requires investigation to identify liver disease, elevated conjugated jaundice. The earlier in life biliary is diagnosed and featured surgically developed diagnosis. Chronic hepatitis B virus infection in children can be prevented. Hepatitis C is curable with oral antiviral drugs, so children and mothers at risk need to be screened. Liver transplantation is effective therapy for acute or chronic liver failure with a greater than 80% 20-year survival rate. Many of the clinical features and complications like this are shown. Liver disease in children are uncommon and should be managed by national centers. Neonatal cholestasis, physiological jaundice in newborns is common, but 90% will have resolved by 2 to 3 weeks of peak term. Prolonged and persistent neonatal jaundice requires formal investigation to distinguish unconjugated and resolve spontaneously from conjugated, which indicates liver disease. Early diagnosis and management in neonatal liver disease improves prognosis. The disease of prolonged jaundice is inversely shown in rocks as bullet point is in prolonged persistent jaundice always lead to see distils of pale, which is as bile obstruction of severe liver disease. Mrcpch, and this occurs in 1 in 15,000 live births. There is progressive fibrosis infiltration of extrahepatic and intrahepatic pituitary. Without intervention, chronic liver failure develops in death occurs within 2 years. The exact etiology is unknown. Clinical presentations in mild jaundice and pale to color may fluctuate, but becomes increasingly pale as the disease progresses. And they have normal birth weight followed by fall in growth. Hepatomegaly is often present initially. Hepatomegaly develops later due to portal hypertension. This is signs, symptoms, encephalopathy, jaundice, epistaxis, cholestasis, fat malabsorption, deficiency of fat and vitamin, pruritus, pale stool, dark urine, ascites, hypertonia, peripheral neuropathy, rickets, secondary vitamin deficiency, loss of fat stools, secondary malnutrition, clapping, pulmonary edema, hepatorenal failure, hypersplenism, familiarity, portal hypertension, reason, and decay, muscle wasting from malnutrition, spinal nevi, and varices with portal hypertension. Most compensation, jaundice, bleeding disorders, and growth faltering. Cause of prolonged persistent neonatal jaundice, unconjugated is breast milk jaundice infection, particularly unitract, hemolytic anemia, GSPT deficiency, hypothyroidism, IgI, obstruction for granular jar, conjugated is more than 25 micromole, bile obstruction, biliary choledochosis, neonatal hepatitis syndrome is congenital infection, aneurysm, metabolism, alpha-1 antitrypsin deficiency, galactosemia, tyrosinemia, type 1, aneurysm, bile synthesis, progressive familial intrahepatic cholestasis, cystic fibrosis, intestinal failure, associated liver disease, associated with long-term parental nutrition, intrahepatic biliary hyperplasia is allergic syndrome. Investigation is a raised conjugated hemoglobin with a raised gamma mile transfer agility and abdominal function test. The fasting abdominal ultrasound may demonstrate contracted or absent gallbladder, though it may be normal. Diagnosis confirmed by ARCP, endoscopy to cholangiopancreatography, which is cholangiogram, or operator, which fails to outline a normal biliary. The liver biopsy initially demonstrates the hepatitis with features of extrahepatic biliary obstruction developing with time. Treatment is palliative surgery with the Kasai hepato enterostomy and leukogenous anastomosis. The gut surface of the porta hepatis bypasses the fibrotic ducts and facilitates drainage of bile from any remaining patent ductals. Early surgery increases the success rate with 50% saving the jaundice if performed before 60 days. Even with successful clearance of jaundice, the disease progresses in most children who may develop cholangitis and cirrhosis with portal hypertension. Nutrition and fat-soluble vitamin supplementation is essential if the Kasai is unsuccessful liver transplantation is essential. Biliary atresia is the single most common indication for liver transplantation in the pediatric age. With choledochosis, there is a cystic dilatation of extrahepatic biliary system. They may be detected when antenatal ultrasound scan present in neonatal jaundice or in old children with abdominal pain or pelvic mass, jaundice, and cholangitis. Diagnosis is established by ultrasound or magnetic resonance cholangiogram, MRCP, And then treatment is by surgical excision of the cyst with the formation of proximal anastomosis lesion. Future complications include cholangitis and 2% risk of malignancy, which may develop in any part of the biliary tree. This is neonatal hepatitis syndrome. Neonatal hepatitis syndrome is prolonged neonatal jaundice hepatic inflammation. There are many causes. Babies may have a low birth weight, faltering growth. Other clinical features depend on the diagnosis. Jaundice may be severe, and differentiation from the biliary that is essentially in biopsies, often non-specific but shows giant cell hepatitis and extramedullary hematopoiesis. Al-Agile syndrome. This is a rare autosomal dominant condition with widely varying penetrance even within families. Clinical presentations with characteristic triangular faces, skeletal abnormalities including butterfly vertebrae, and congenital heart disease, lastly, peripheral pulmonary stenosis, related disorders, and defect in the eye. Infants may be profoundly cholestatic with severe pruritus and faltering growth. Identifying the gene mutation confirms the diagnosis. Treatment is required nutrition and fast soluble vitamins. Pruritus is profound and difficult to manage. A small number will require liver transplant, but most survive into adult life. Mortality is most likely secondary to cardiac disease, progressive familial intrahepatic cholestasis. These autoimmune recessive disorders all affect by soil transport. Cynical's vegetation with jaundice, intense pruritus, faltering growth rickets, and in some cases diarrhea and hearing loss. Other original represented cause diagnosis is confirmed by identified mutations in soil transport genes. Treatment is with nutritional support and fat-soluble vitamins. New drugs includes ileal bile acid transporter inhibitors, which prevent bile-soluble absorption and improve pruritus. Progression of fibrosis is usually with most requiring liver transportation. Cases with biliary determined from birth with 3.4 kg when sexually breastfed and developed my jaundice on the third day of life. 5 weeks, she was still jaundiced. She was constantly angry, on an infant formula, on cushioning. Her stool were pale, but there were no other features of liver disease. Investigation with cylinder 160 micromole with a 140 micromole conjugated. She has conjugated hyperbilirubinemia. She was referred to a national pediatric liver center with further investigation read. ALT elevated 120 in the national unit. But later, GGT was elevated 430, ultrasound absent gallbladder despite 4 hours of fasting. This is basal secondary to biliary atresia. Several months after successful bile drainage, hematopoietic Kasai syndrome, Kasai procedure for biliary atresia started from her surgery. And treatment with fat soluble vitamins and also deoxycholic acid were commenced. Feeds were changed to high, medium chain triglycerides feed, and she settled on the 3 hour feeding pattern. No other causes of conjugated jaundice were identified. An operated cardiogram confirmed atresia and she had a side photo and test which made 6 months of age shows her a few months after admission. At 4 years of age, she had developed increased splenomegaly and is to be identified with sufficient varices. She remained stable at the age of 6 years. Bullet is prolonged persistent nasal jaundice, early jaundice, and biliary atresia improves the prognosis. So all term infants with jaundice and TBs should be investigated for liver disease. And this is the typical facial features of agile, and with the pointed chin and wide-spaced eyes and prominent head. Okay. Neonatal metabolic liver disease, alpha-1 antitrypsin deficiency. It is inherited as an autosomal recessive disorder with incidence of 1 in 2,000 to 1 in 4,000 in the UK. There are many phenotypes of protease inhibitor which are coded on chromosome 14. With liver disease primarily associated with the protein phenotype PICC, abnormal folding of protease, alpha-1 antitrypsin associated with accumulation of protein within the hepatocytes and hence liver disease in infancy and childhood. The lack of circulating alpha-1 antitrypsin results in emphysema in adults, especially if they're exposed to cigarette smoke. The majority of children who present with alpha-1 antitrypsin will either have prolonged neonatal jaundice or less commonly bleeding due to vitamin K deficiency. Emergency disease of the newborn. Hematomegaly is present. Diagnosis is confirmed by estimating the level of alpha-1 antitrypsin in the plasma and identifying the proteins phenotype. Approximately 50% children have a good prognosis, but the remainder will develop liver disease, cirrhosis, splenomegaly, portal hypertension, and may require transplantation. Pulmonary disease is not significant in childhood and may develop in adult life. Advice to avoid smoking. Both active and passive should be given. The disorder can be diagnosed anti-lethally. Galactosemia, this very rare disorder, has an incidence in 1 in 23,000 to 1 in 44,000. Infant develops poor feeding, vomiting, jaundice, hepatomegaly when fed, nose level failure, characterized in developmental delay, are inevitable if it is untreated. A rapidly fatal course with shock, hemorrhage, and disseminated intravascular coagulation often due to graft like deception may occur. On investigating prolonged persistent jaundice, it can be identified by detecting galactose, a reduced substance in urine. The diagnosis may be made the enzyme galactose 1-phosphate uretine transferase injections. A recent blood transfusion may mask the diagnosis. Galactose-free diet prevents progression of liver disease, but ovarian failure and learning difficulties may occur later. Other causes of neonatal hepatitis may occur following prolonged parenteral nutrition. Rare causes include tyrosinemia type 1, cystic fibrosis, lipid and glycogen storage diseases, peroxisomal disorders, and lung cancer bile synthesis. In viral hepatitis, the clinical features of acute viral hepatitis include nausea, vomiting, abdominal pain, lethargy, and jaundice. However, 30 to 50% of children do not develop jaundice. A large tumor liver is common, and 30% will have splenomegaly. The liver transaminases are usually markedly elevated. Coagulation is usually normal. So Hepatitis A is an RNA virus which is spread by fecal route. Incidence of hepatitis A in China has fallen as socioeconomic conditions have improved. Many adults are now not immune. Vaccinations required for travelers to endemic areas. The disease may be asymptomatic, but the majority of children have a mild illness, recover both clinically and biochemically within 2 to 4 weeks. Some may develop prolonged cholestatic hepatitis, which is self-limiting or permanent hepatitis. Chronic liver disease does not. Diagnosis can be performed by detecting IgM antibody to virus. There is no treatment, no waiting set by bed rest or treatment diet is effective. Those contacts should vaccinate within 2 weeks of the onset of illness, and those at increased risk, chronic liver disease, human normal hemoglobin should be considered. Hep B is a DNA virus, an important cause including chronic liver disease worldwide with high prevalence of carrying rates in sub-Saharan Africa and Far East. HPV is transmitted by perinatal transmission from carrying lipids or horizontal spread between families. Inoculation with infected blood transfusion, lethal injuries, or during dialysis. Among adults, it can mostly transmitted sexually. Infants who contract children perinatally is asymptomatic, but at least 90% become chronic carriers. Older children who contract usually may be asymptomatic and have a classical features include hepatitis. The majority resolve spontaneously, but 1 to 2% develop fulminant hepatic failure, while 5 to 10 become chronic carriers. Their diagnosis made by detecting HPV antigens and IgM antibodies to report anti-HPC are positive in an acute infection. And hepatitis B surface antigens is when HBS surface antigens denotes ongoing infectivity. There is no treatment for acute infection. Chronic Hep B, approximately 30 to 50% asymptomatic carrier children will develop chronic HBV, liver disease, progressive forces in 10%. There is a long-term risk of hepatocellular carcinoma. Current treatment regimens for chronic HBV has poor efficacy. Interferon to be dilated interferon long-acting formulation treatment for chronic Hep B successful in 50% children infected horizontally and 30% infected perinatally. Oral antiviral therapy such as intensivir and tenofovir are licensed for treatment children more than 2 years and clears the virus in 25%. Long-term treatment may be required. Prevention of HPV is an important immunization with ABV vaccine is now part of the routine immunization schedule in the UK and many other countries. In addition, all pregnant women test screening for HPS antigen and if identified as HPS antigen with infectivity positive are offered additional doses of the vaccine for the infant starting and growth. If the mother is also Hep B E antigen positive, giving the infant B immunoglobulin shortly after birth and plasma device. Antibody response antibody response to the vaccination course should be checked out 12 months to effects of surface radiation caused mothers as 5% require further vaccination. Other members of the family should also be vaccinated. Neonatal vaccinations reduce the incidence of HPV-related cancer in public countries. Hep B virus perinatal transmission from carrier mothers should be prevented by maternal screening and giving the infant course of Hep B vaccine that have been globally indicated. Hep B immunization is part of the routine immunization in the UK and other countries. Infection result from chronic HPV disease with progressive resistant hepatocellular carcinoma. Hep C virus is an RNA virus that was responsible for 90% of transmission hepatitis until its training donor blood was introduced in 1991. In the UK, about 1 in 2,000 boys have HCV antibodies. Prevalence is high among HIV drug abusers. Vertical transmission is now the most common cause of HCV transmission. Children 6% transmission happens from the infected mothers, but is twice as common if there is co-infection with HIV. It seldom causes an acute infection with the majority becomes chronic carriers, like 20%, 25% lifetime risk of progression to cirrhosis and hepatocellular carcinoma. Oral direct acting antiviral drugs such as cephalosporin and letifosfir, the combination was beware tastrobamarine and lacaprevir and Vibrantacor, 8 to 100% curative license in children more than 3 years in the US and more than 12 years in Europe. Effective therapy for severe when significant liver disease and liver cancer, highlighting the need to screen high-risk mothers and children. Treatment is not indicated for 3 years of age. It's a main resource for release following vertically acquired infection. Hep B is defective RNA virus that develops depends on Hep B virus for replication. It occurs as co-infection Hep B or as a super-infection causing an acute exacerbation of chronic Hep B. Cirrhosis develops in 50-70% usually develop chronic HBV infection. HE is RNA. This is entirely transmitted usually by contaminated DNA is found worldwide but is more prevalent in low-income countries. Hep E causes a mild circulating illness most people and is lost to transfer the blood transfusion not eating effectively. In pregnant women, it causes fulminant hepatic failure with a high mortality rate. Seronegative non-A G hepatitis. Clinical presentation is similar to Hep A. When a viral hepatitis is suspected but not identified, it is called like seronegative hepatitis. Epstein Barr virus, children with Epstein-Barr virus infection are usually asymptomatic. Some 40% have hepatitis with mild hepatitis B and belly, which may become fulminant. Less than 5% majorities. Acute liver failure, fulminant hepatitis. Acute liver failure triggers the development of massive hepatic nephropathy, subsequent loss of liver function within adult hepatic encephalopathy. The disease is as common but has a high mortality. Most are caused by infection and metabolic condition. The child may present within hours or weeks with jaundice, encephalopathy, coagulopathy, hypoglycemia, and electrolyte balance. Early signs of encephalopathy include alternate irritability and confusion with drowsiness. Older children may be aggressive and unusually difficult. Complications include cerebral edema, hemorrhage from bursitis, including coagulopathy, sepsis, and pancreatitis. Diagnosis and the bilirubin may be normal in the early stage, particularly with metabolic disease. Transaminases are greatly elevated, 10 to 100 times normal. Alkalized phosphatases increased, coagulation very abnormal, and pass on as allergy. This is usually mother the acid-base balance, blood glucose and coagulation times, and EG will show acute hepatic encephalopathy and a CT scan will demonstrate cerebral edema. Management early referred to national pediatric liver center essential steps to stabilize the child prior to transferring fluids, maintaining the blood glucose more than 4 millimole with IV textures, preventing subsequent watching antibiotics and defibrillation, preventing hemorrhage, particularly from the GI with IV. Vitamin K should be issued properly. H2 blockade drugs and photoapper inhibitors. Prevents cerebral edema by fluid restriction and monitoring dialysis if edema develops. Features in intraocular prognosis are shrinking liver, rising the liver with falling transaminases, worsening coagulopathy or production to coma without liver transplantation. 70% of children make progress to coma with liver disease in which causes chronic liver disease. Clinical presentation varies within a period of hepatitis with serious development of hepatitis with megaly cirrhosis. and polyhepatitis, lethargy, and malnutrition. The most common causes of hepatitis virus B and C. Autoimmune hepatitis is a non-alcoholic fatty liver disease, but its disease should always be excluded. Autoimmune hepatitis includes cirrhosis and cholangitis. The mean age of presentation is 7 to 10 years. It's more common in girls who present as acute hepatitis. As fulminant hepatitis-related chronic disease, autoimmune features such as skin rash, arthritis, multiple or nephritis. Diagnosis based on elevated TB13, hypercholesterolemia, IgG 20. Positive autoimmune bodies elucidate complements 4 and typical histology. Autoimmune hepatitis may occur in isolation or in association with inflammatory bowel disease, celiac disease, or other autoimmune diseases. 90% children with autoimmune hepatitis will respond to penicillin as a thyroid. Sclerosing cholangitis is treated with sodium-deoxycholic acid. Cystic fibrosis is multi-organ genetic disorder disease due to abnormalities in cystic fibrosis, trans-membrane regulated CTFR gene, as already described in 17, which is very liver disease is second most common cause of death after respiratory disease, and most common abnormalities of hepatic steatosis, fatty liver. It may be associated with protein energy malnutrition, micronutrient deficiency. Steatosis does not generate progress, and treatment involves ensuring optimal conditions. More significantly, liver disease arises from tenacious bile with abnormal bile acid concentration leading to progressive liver fibrosis. Cirrhosis and protein hypertension develop in 20% children. By causes of chronic liver disease, post-viral obesity, and autoimmune hepatitis, including meningitis, drug-induced liver disease, safe cystic fibrosis, disease, polycystic liver disease, non-alcoholic fatty liver disease, alpha-1 antitrypsin. By mid-doses, early liver disease is difficult to detect by biochemistry over some area. So, organic liver histology includes fatty liver, focal biliary fibrosis, or focal motor cirrhosis. Supportive therapy includes endoscopic treatment of viruses, nutrition therapy, and treatment with ursodeoxycholic acid. And experience with the new safety and mobility senses of diseases. Failure is limited, but some may cause increased transaminase liver transplantation, maybe the leukocytes with end-stage liver disease, either alone or in combination with heart and transplant. This disease is not a basis disorder with incidence of 1 in 2 lakh. Many nutritions have now been identified. The basic genetic effect is a combination of reduced insulin causing the copper building protein and defective excision of copper in the bile, which leads to accumulation of copper in the liver, brain, kidney, and cornea. Wilson disease usually presents in children under the age of 3 years. In those presenting a childhood hepatic presentation is more obvious, but subtle neurological damage is likely to present. They may present with almost any form of the disease, including acute hepatitis, family hepatitis, cirrhosis, and hypertension. Neuropsychiatric features are more common in these, presenting from the second decade onwards, including deterioration in school performance, behavior change, and extrapyramidal signs, and system coordination, tremor, and dysarthria. Renal tubular dysfunction with vitamin D resistant rickets are and hemolytic and may also occur. Copper accumulation in chronic case of Fisher. Case of Fisher rings is not seen for 7 years. Low stone passing in copper is characteristic but not universal. Usually, copper excretion is increased, and this further increases after administrating the chelating agent penicillamine. And however, the diagnosis is confirmed by the finding of elevated hepatic copper or biopsy or amplification gene mutation, APP7B, treatment with penicillamine and tridentine, both for remain copper excretion, reducing the factor of the nervous system. Zinc is given to reduce copper absorption. Hydroxy is given to prevent peripheral zinc is used in asymptomatic children. And this is just official labels. And sorry, this is just the official things. And these are defined by screening families with legs. Case, biological improvement may take up to 12 months of therapy. About 30% children may see disease will die from hepatic complications if untreated. Liver transplantation considered future. Acute liver failure is severe and stage liver disease, fibropolycystic liver disease, ciliopathies. This is a range of genetic conditions affecting the development of intrahepatic biliary presentations in liver cystic disease or fibrosis and renal disease, congenital hepatic fibrosis presents in children over 2 years with hepatic splenomegaly, abdominal dissension, and portal hypertension. It differs from cirrhosis in that liver function tests are normal and in early stage liver histology shows large bands of hepatic fibrosis containing abnormal platelets. Complications include portal hypertension, varices, and recurrent cholangitis. Cystic renal disease may occur and this may cause hypertension, renal dysfunction, indication of a liver transplant, includes severe recurrent cholangitis or deterioration of renal function requiring renal transplant, in which case a combined transplant could be offered. Non-alcoholic fatty liver disease is a single most common cause of chronic disease in high-income countries. Suspected disease ranging from simple fatty deposition steatosis through root emission steatohepatitis, fibrosis, cirrhosis, hepatocellular carcinoma, and end-stage liver failure. China may not. It may be associated with metabolic syndrome or be the obesity. The prognosis in China is uncertain. Who develop cirrhosis in childhood in contrast to 8 to 70% adults. They're usually asymptomatic, although some complain of vague right upper quadrant abdominal pain or lethargy. Diagnosis is often suspected following the incidental finding of echogenic liver or ultrasound or mildly elevated transaminases carried out for some other reason. Liver biopsy demonstrates marked steatosis with or without information of fibrosis, but pathogenesis is not fully understood but may link to insulin resistance. Treatment targets weight loss through diet and exercise may lead to liver function tests, complications, nutrition, effective nutrition essential. It may improve and stabilize patient liver disease. Barrier to effective nutrition include fat malabsorption, long-chain fatty acids, fats, long-chain fat is not effectively absorbed by therefore medium-chain fat is effective in milk, especially excuse me, guys, it is required if children are persistently cholestatic as it is not required. Bile size for absorption, up to 40% of fat needs to be long chain fat to prevent. This is effective fat soluble vitamin A, D, E, K, and vitamin K bleeding diastasis, going to bleeding, vitamin A, rectal change in defense, and vitamin solution, peripheral neuropathy, monocytic ataxia, vitamin D, infection, sensitive fatty acid deficiency, fat soluble vitamins are carried on the long chain fat. The deficiency is common unless vitamin is supplemented. Protein malnutrition, poor intake of vitamin, high catabolic rate of disease, liver, make protein malnutrition common representation of liver disease. Protein intake should not be restricted unless the child is acutely and capnopathic. Anorexia, when unwell children cannot take the required amount of nutrition, many will require nasogastric tube feeding or occasionally parenteral. Fat soluble vitamins, all fat soluble vitamins can be given orally, monitoring the level and adjustment of doses required to prevent deficiency. In severe deficiency, IM administration may be required. Pruritus, severe pruritus associated with cholestasis, although the etiology is not clear, pruritus difficult to manage may lead to exfoliation of skin. Loose cotton clothing, avoiding overheating, keep nails short, moisturizing the skin with emollients, medication, phenobarbital, simulate bile cholestyramine, a bile salt resin to absorb bile salts, so deoxycholic acid, and oral bile acid to solid bilize the bile fampicin enzyme reducer and the new ileal bile acid transporter inhibitors. Encephalopathy is a present in liver disease and being precipitated by GI hemorrhage, sepsis, sedatives, renal failure, electrolyte imbalance. This difficult to diagnose in children's level of consciousness may vary throughout the day. It represents irritability, sleeplessness, while orgasm present with abnormality in mood, sleep rhythm, intellectual performance, and behavioral disturbances. Basal ammonia may be elevated in EEG is always abnormal. Oral lactulose and a non-absorbable oral antibiotic rifaximin will help reduce ammonia by lowering the colonic pH and increasing transit time. Sorry. And these are this picture. This is the liver that has been removed in time transplant. This vehicle says the liver is really nutrient diabetic by the time the earliest is indicated. And so support hypermalnutrition, loss of fat in the stomach, hematomegaly, and swelling from ascites. This is pruritus, this is cirrhosis, inflammatory cirrhosis. The end result of many forms of liver disease is defined pathologically as extensive fibrosis where regenerative nodules may be secondary to hepatocellular disease or to chronic bile duct obstruction. Cirrhosis main physiological effects of those that diminish hepatic function, portal hypertension, splenomegaly, varices, and ascites. Hepatocellular carcinoma might develop. Children with compensated cirrhosis may be asymptomatic if lymph function is inadequate. They will not be jaundiced and may have normal liver function tests as the cirrhosis increases. However, the result of deteriorating liver function both hypertension without copies. Physical signs include jaundice, tremor, and plantar erythema, telangiectasia, and spondylosis, malnutrition, hypotonia, related abnormal veins, and splenomegaly suggests both hypertension, although the liver may be shrunken and impalpable. This is facial telangiectasia, spondylosis. This is tense ascites in baby, and investigation includes screening for the known cause of chronic disease, upper GI, includes to be to detect the presence of esophageal varices and erosive gastritis. Abdominal ultrasound may show shrunken liver and splenomegaly with gastric and esophageal varices. Liver biopsy may be difficult because of increased fibrosis, but may indicate that there is typical changes in congenital hepatic fibrosis, copy storage as cirrhosis decompensates. Biochemical test may demonstrate an elevation of amino transferases and alkaline phosphatases. Plasma environment falls with trauma in time becomes increasingly prolonged. Esophageal viruses, they are inevitable consequence of portal hypertension and may develop rapidly in children that are diagnosed by upper GI endoscopy. Acute bleeding treated with blood transfusion, extra water, nicotine, or omeprazole, absorbed infusion, vasopressin, analogs, endoscopic band ligation, stereotyping may affect it. Though Intracameral shunts may preclude lymph transplantation, but radiologic placement of stand between hepatic and means transjugular intrahepatic tips systemic shunt can be used as step-free if transplantation is being ascites is a major problem. Vascular ascites is uncertain, but contributing factors include hypoammonemia, sodium retention, and sodium retention and nutrition diet. Additional therapy for refractory ascites includes albumin infusion or paracentesis and spontaneous bacterial peritonitis. This should always be considered if there is undiagnosed fluid abdominal pain, tenderness, unexplained deterioration of abdominal function. Diagnosis of paracentesis should be performed if fluid sent for white blood cell count differential in cultures. Treatment with broad spectrum renal failure. This may be secondary to renal tubular acidosis, acute tubular necrosis, or functional renal failure. Hepatorenal syndrome is liver transplantation is an accepted therapy for acute or chronic ancestral liver failure and has some functional prognosis for additional transplantation is also considered for some hepatic malignancy, hepatoblastoma, hepatocellular carcinoma, and indication of transplantation for chronic disease, severe malnutrition, unresponsive to intensive nutrition therapy, complications affected to medical management, bleeding varices, resistance, ascites, failure of growth and development group for reduced example evaluation includes assessment of the vascular anatomy of the liver and exclusion of irreversible disease in other cells. Absent consternation includes sepsis and treated cardiopulmonary disease or cerebrovascular disease. There is considerable difficulty in obtaining small levels for children. Most children receive part of their adult's liver either into cadaveric graft or more recently from living related donor and cadaveric organ may either be reduced to fit the child's abdominal reduction hepatectomy or split shared between an adult and child. Complication for surface include primary non-functional the liver, 5% hepatic arteriosclerosis, 10 to 20% biliary leaks and fissures, rejection 30 to 60%, such as main positive. In large mushroom centers, overall 1 year survival is approximately 90% within 20 years survival is greater than 80%. Most deaths occur in the first 6 months. Children who survive initial post-op period usually do well. Long-term is immediate normal psychosocial development and quality of life in survivors. This is the end of liver.